So good afternoon, everyone, or good evening yeah, it's quite evening already. It's my pleasure to present today's MissINFORMED webinar with a topic dear to my heart, and that's actually all the heat of the hour in all aspects of medicine, trauma-informed care, and more specifically in gynecology and abortion care. So first of all, allow me to extend my gratitude to Clara, who was one of my first LinkedIn connections, actually, and we have chatted back and forth for quite a while now, and I couldn't help but notice our interests are very similar. So I appreciate it from the bottom of my heart that you have thought of me for a MissINFORMED webinar. So yeah, to more great collaborations. So let's get started. My name is Sergiu Vlad. I'm a Université de Montréal trained OBGYN who subsequently went on to acquire some extra training in family planning at the University of British Columbia in Vancouver. For those of you who are not familiar with family planning, it's a branch of gynecology that specializes in advanced or late pregnancy terminations, as well as complex cases of contraception. So being on the front lines of vulnerable, sometimes extremely vulnerable patient care, I was appalled to notice some of the behavior that my colleagues were showing towards patients that was at times unacceptable in my point of view, and that prompted me to get more in depth in the topic of trauma and violence-informed care. So first and foremost, I would like to acknowledge that I'm humbled to present on the unceded indigenous lands of the Mohawk people. The Kanawake Nation is actually recognized as the custodians of the lands and waters on which I am reaching you today. And so I would like to take a moment to present you the huge territory of the Mohawk Nation that ranges from Lake Ontario in the west to the St. Lawrence Gulf in the east, and also encompasses some of the Vermont region from our neighbors down south. If this is a fact that you already knew about the Montreal's host nation, I invite you to visit kanawake.ca website, where you can find different resources to learn more about them. And what's great about this website is that the information and resources were actually created by people from the nation itself, so as to respect and preserve their authenticity and reduce the mark of colonization. And if you're not aware of the traditional ancestral territory that you're living in, I'm also inviting you to research and educate and learn more about them after the presentation. So let us begin. I do not have any conflicts of interest to disclose. However, today's presentation does address some sensitive topics related to trauma, which some may find triggering. So please take a break at any time to attend to your own self-care when needed. So today's objectives are threefold. First of all, we will explain the impact and consequences of traumatic experiences for individuals, families, and communities from a trauma-aware framework. Then we will learn the core principles and practices that reflect trauma-informed care and how it integrates into reproductive health care in order to finally decrease the inadvertent re-traumatization by implementing a new standard of care in gynecology and family planning practices. So quite a full plate. So trauma, what is trauma? How do we define it? So trauma is a broad term used to describe the challenging emotional consequences that living through a distressing event can have for an individual. Traumatic events can be difficult to define because the same event may be more or less traumatic for some people than for others. According to the Substance Abuse and Mental Health Services Administration, it's a US department, trauma results from an event, series of events, or series of circumstances that is experienced by an individual as physically or emotionally harmful or threatening, and that has lasting adverse effects on the individual's functioning and social, physical and emotional well-being. So trauma can affect people of every race, ethnicity, age group, sexual orientation, gender, you name it, it can affect anyone. And it can be a single event, a series of events, or a chronic condition, such as childhood neglect, domestic violence, ongoing domestic violence, childhood disease, etc. So traumas can affect, at the same time, individuals and their families, but also groups, communities, and cultures. And lastly, generations. It ignites the fight, flight, or freeze reaction at the time of the event, but then proceeds to generally overwhelm an individual's or a community's resources to cope, therefore frequently producing a sense of fear, vulnerability, or helplessness. And what's even more remarkable is that trauma can actually be passed down from generation to generation, a phenomenon that's called intergenerational trauma, which I'm sure some of you have heard of, where members of the same genetic heritage of someone who experienced a violent trauma are equally affected by the same traumatic event, even though they themselves have not experienced it. So this phenomenon is not yet fully understood, but some experts think that the original traumatic event could affect your relatives' relationship skills, personal behavior, attitudes and beliefs, coping mechanisms in ways that affect future generations of your family. For example, communities affected by trauma tend to adopt the same coping mechanisms as the individuals affected by trauma themselves, including hypervigilance, lack of trust, retreat into silence. And some other researchers are also looking into the possible role of epigenetic changes. So this is the idea that the environment or how we live our lives could cause changes that affects the way our genes work. And these changes could be passed on to younger generations. So the repercussions of trauma can be on quite a large scale. When we look at it from a healthcare point of view, traumatic experiences can and often do impact both mental and physical health. So remember that the effects of trauma are different for each individual. Traumatic events experienced early in life, such as abuse, neglect, disrupted attachment, can often be devastating. There is also a dose-response relationship between adverse childhood events and adverse health outcomes and behaviors, such as, for example, chronic conditions, chronic pelvic pain, other chronic diseases such as depression, hypertension, avoidance and mistrust towards reproductive health care, which subsequently have been associated to high rates of STIs, avoidance of adequate cervical cancer screening, late entry to prenatal care. So all these things are very well demonstrated in the literature as potential consequences of experiencing traumatic events. However, other life experiences that are out of one's control, for example, a serious accident, a child dying before a parent, cancer as a teen, being the victim of violence, living through a natural disaster or war, can be equally challenging, even if they are not necessarily early onset. How an event affects an individual depends on many factors, including personal characteristics, the type and characteristics of the event itself, the meaning one attributes to said trauma, socio-cultural factors, but one of the most important ones are our taught developmental processes. So ways we have learned from our parents, all life experiences, formal education, society norms, that will determine how we respond to trauma on an individual level. And so if we will have a healthy response to trauma versus a poor or maladaptive one. So for most people, regardless of the severity of the trauma, the immediate or enduring effects of trauma are met with resilience. Resilience is by definition the opposite of trauma, the ability to rise above the circumstances or to meet the challenges with fortitude. When thoughts and memories of the traumatic event don't go away or get worse, they may lead to post-traumatic stress disorder, which can seriously disrupt a person's ability to regulate their emotions, maintain healthy relationships, and a healthy functioning in society. Some individuals may clearly display criteria associated with PTSD, which are listed in the DSM-5, the psychiatric Bible, but others do not meet the established criteria, but still do encounter significant trauma-related symptoms or culturally expressed symptoms of trauma. For example, some patients may experience somatization, in which psychological stress is experienced through physical concerns, like migraines, Clara, I'm watching you, arthralgia, chronic pain. For that reason, even if an individual does not meet diagnostic criteria for PTSD, it's important to recognize that trauma may still affect their life in significant ways. In fact, the majority of individuals will exhibit resilient responses. So all this is to say the impact of trauma can be either subtle, insidious, or outright destructive, but we cannot assume it will be one way or the other for any person we meet. And so that's where the trauma-informed care framework comes in. So what is trauma-informed care? Why do we need it? What led to it? So let's first look at the prevalence of trauma in women at large, in those seeking reproductive health care, as well as in abortion care settings. We all know that the numbers are large. And so I got a few statistics for you. One woman out of 5 who experiences a trauma will develop PTSD. So that's quite a lot. And the most common trauma exposures in women are rape, sexual molestation. And we know this to be true. Sexual violence disproportionately affects women, girls, as well as transgender, gender diverse people, with reports citing 1 in 3 women experiences sexual assault, and 1 in 8 trans feminine people experiences intimate partner violence in their lifetimes. When we look at the world, the lifetime population prevalence of PTSD in women is 7% in Sweden and 10% in the US, respectively. It's also more prevalent in women of color, as well as women in the carceral and military environments, with numbers up to 1 in 4 women reaching criteria for PTSD in those groups. Sexual trauma is particularly common among people seeking reproductive care. When we look at studies on abortion, studies tend to show that most women cope well with abortion. And the strongest predictor of mental health problems after an induced abortion is, like many things in medicine, their pre-existing mental health status. So if someone was already affected by some traumatic event in their lifetime, they are more likely to develop PTSD after an abortion. In 2013, a Swedish multi-center study of women requesting an abortion was set up to describe the prevalence and pattern of traumatic experiences, namely the prevalence of PTSD and PTSS, which are post-traumatic stress symptoms, so not yet a disorder, in women requesting an abortion. And the main findings of the study were that women who requested an induced abortion had a point prevalence of PTSD of 4%, which is even a bit less than the prevalence in the population, which was 10%, but as many as 23% has post-traumatic stress symptoms. So needless to say, the experience of trauma is prevalent, often unrecognized, and multifactorial, especially for those seeking reproductive healthcare. But we have to remember, reproductive healthcare can absolutely also be a source of primary trauma, as well as re-traumatization. That the history of trauma influences a person's health, relationship, experience, and use of reproductive healthcare, as well as their trust in reproductive health recommendation and providers. The experience of gynecology care itself can be the initial trauma and can be re-traumatizing for many groups of people. And there's a myriad of examples that this can be done through, such as invasive examination or questions, minimizing pain symptoms, not offering anesthesia, recreating power dynamics that reactivate the trauma experience. So as gynecologists, we have a pivotal role to play in providing trauma-informed care and reducing this risk of re-traumatization of patients. What's important to recognize first and foremost is that some parts of medicine were founded on systemic racism, discrimination, and medical misconduct, such as forced and coercive contraception and sterilization. After all, our modern gynecological tools that we still use today, like the speculum, for example, were invented by men who were seen like pioneers in their own time, but who actually gathered much of their learnings by operating on enslaved Black women without their consent or without anesthesia, and stating ludicrous things like Black women feel less pain, they have less pain receptors, which have no basis in science itself. But we don't have to go far to find some other well-known examples. Here in Canada existed a time in which doctors, and that's not that far away back in time, doctors were performing sterilizations and hysterectomies without consent, affecting mostly Indigenous women and lower socioeconomical class women. So our history is unfortunately rich of examples. However, trauma still exists today, and it still does in a more pervasive, more insidious way that we could not think it can be considered as assault, but it actually is. So I think it's therefore mandatory that we take a look towards the self and ask ourselves this painful question: have I ever assaulted a patient? Have I ever traumatized a patient? And this is a slide that is destined to make my colleagues uncomfortable because I believe that in discomfort, we can find the will to change. And you would be surprised to know that every time, almost everyone in the room admits to having contributed to a patient's trauma or assault. Some unconscious behaviors that can trigger trauma are often minimized. For example, something as simple as pushing down a woman's knees so she would open her legs a bit wider during an exam, or denying a patient an epidural because they aren't in active labor yet. Examining a patient in emergency situations without having asked the consent first, performing a general examination faster when the patient is clearly uncomfortable and retracted her consent. We even dabble into reproductive coercion when we negotiate with patients who want their IUD removed. That's not our place. We can support, understand, offer alternative, but not negotiate. Or when we refuse a younger patient the ability to access permanent contraception. Some of my colleagues still think that those can all be justified because it's done in the patient's best interest. But trauma is pervasive and it will stick with us, even if we end up convincing our brains that it was done in our best interest. It will manifest unconsciously and create wider gaps between us and those who truly want to help us. And so healthcare professionals and clinical staff need to be aware of the impact of trauma and the risk of causing further harm in clinical encounters. So with this in mind, the mandates of trauma-informed care are twofold. So first, to actively avoid re-traumatization. And second, to efficiently link our patients to trauma-specific services when needed. So a dedicated service corridor to psychoeducators, psychologists, counselors, social workers, psychiatrists. But having a great trauma-specific referral system is not good enough a substitute for practicing individual trauma-informed care with all our patients. So how do we do that? So let's check out some concrete applications of the framework. Starting with a little bit of background information. So providers began defining and exploring trauma-informed care, or TIC, or the trauma-informed approach, TIA, in the beginning of the 2000s. And it began as a framework for acknowledging and addressing the effects of trauma in healthcare service provision, particularly in disciplines like pediatrics, psychiatry, where it was more important to provide this kind of care. However, it dates back as far as the 70s, when the physical and mental traumatic experiences that Vietnam War veterans experienced necessitated a specific approach by healthcare providers. Out of the study and treatment of this population came the diagnosis of post-traumatic stress disorder and the framework for trauma-informed care, as well as the awareness that trauma, especially multiple traumas and repeated traumas, can affect the way in which the brain, the nervous system, and the body at large functions or malfunctions. So TIC, trauma-informed care, is distinct from providing treatment for trauma, but rather seeks to provide all care in a way that acknowledges the pervasiveness of traumatic experiences, be it that the patient has had a traumatic experience in the past or did not. It aims to integrate knowledge and assumption about trauma into policies, procedures, and practices, and seeks to actively resist re-traumatization. Because we know that most people that have faced trauma in their life will not disclose it. And so by having this general trauma-informed, trauma-aware approach, it actually creates a sense of safety. Well, it aims at creating a sense of safety for the patient to be able to receive the best care that they can. So basically, trauma-informed care is provided assuming past trauma in all dispensed care with a mandate to actively avoid re-traumatization. And there are 6 key principles defined in this framework. So those are safety, So to ensure the patient feels safe, physically and psychologically. Second of all, transparency and trust, because we know that once trust is lost, it creates doubt, and patients then feel like there is a problem with themselves or proceed to not come back to appointments and not follow treatments, etc. Peer support and collaboration, peer support and healing, I'm sorry, collaboration or decision sharing between physicians and patients, empowerment and building resilience. So this is one of the key principles of trauma-informed care, because it aims at providing patients with specific tools to develop better coping mechanisms, better coping tools in response to trauma. And finally, addressing structural and historical trauma. So this framework has long been embraced in some medical fields like mental health, primary care, pediatrics, like we stated before. However, it has been challenging to incorporate in reproductive health care, as our standard care often mimics or reinforces prior traumatic experiences, namely sexual molestation, coercion, and abuse. So and especially for male providers. The mainstay for providers of trauma-informed reproductive healthcare is to realize that, one, trauma is prevalent on many levels of our care. Even a simple gynae examination. Second, seek to provide care emphasizing patient safety and resilience. And third, work to reduce the barriers that cause additional trauma. These are guidelines that are suggested by the SAMHSA for providing care that is aimed to promote patient safety, empowerment, and healing, 3 of the 6 categories in the trauma-informed care framework. Many of these require additional patience and empathy for patients, even those who have not disclosed a particular trauma, but you will see that they should become second nature, as they are basically based on human interaction, mutual respect. So let's go through these together. To promote psychological and physical safety, some trauma-informed tenets include having an awareness of the physical space, so considering spatial positioning of the patient and the provider, which instruments are visible, which are out of sight, to increase a sense of safety. No chair back to the door, no interposition between the door and the patient, having private space to change, promote the presence of a support person for all examination and procedures when possible, walk in front and not behind a patient, minimize body exposure, meet patients while they are fully dressed, and ask patients to remove clothing themselves if need to uncover a part of their body for an exam. Most paramount is to avoid instauring power dynamics. So sitting at an eye level, not from above. Do not appear distracted, appear fully engaged in the conversation. Formal introductions of the entire team. Consider the impact of a security presence. This is more so in the States or other locations where abortion services are illegal, and continue to fight against abortion restrictions that make safe care less accessible. So this is also more for the United States. Empowerment. So empowering patients means to give them back the control in all parts of examinations and procedures. So first of all, what I tend to always ask before a vaginal examination or a speculum examination is if there is anything about prior pelvic examinations or procedures that would be helpful for me to know prior to this examination. How were previous examinations experienced in the past? What did the provider make to make them more comfortable? So we have to explain the purpose of each procedure, allow space for refusal, and obtain consent throughout. Ask if there's anything to make the examination more comfortable. This can include explaining more, explaining less, listening to music, etc. Ask the patient about preferred language. So this includes translator services if needed, preferred name, pronouns, and words for body parts. Ask permission to obtain consent prior to and throughout all examinations and procedures. Offer patients to place instruments themselves, including ultrasound probe and speculum, and let them know if they ask you to stop, you will stop. So this is paramount in ensuring a sense of safety in patients and sensing that they can trust you as a provider And this is saying the truth and being held accountable for said truth. And finally, healing. So while the historical trauma of reproductive health cannot be erased, policies and practices can promote healing and trust. So acknowledging historical trauma. So straight up state that one of the explicit goals here is to avoid re-traumatization and rebuild trust. So this is something that I often tell my patients when they tell me about prior painful IUD insertions and anecdotes from family members or friends that lived certain parts of gynae care as traumatic. And so I state with them firsthand that my goal is not to traumatize them. And if there's anything that they think I should be doing in order to not traumatize them, I will do it. And so this includes extra anesthesia. This includes general anesthesia or regional anesthesia, like an epidural for IUD placements or removals, etc. Recognize and address systemic racism on which OBGYN has developed, so notably through the assault of enslaved, unanesthetized Black women. So we must be aware of this legacy, recognize distrust as a symptom of trauma, and seek to both heal and prevent further re-traumatization. So it involves getting back the speculum, so allowing them to manipulate the speculum, insert it themselves, choose a size, opt for alternatives. Notably, there's a startup in the States that is currently developing a new speculum. It's still in the phases of development, but it's a speculum that's actually checking quite a few marks that patients themselves have brought up as ways to make the speculum examination more comfortable. Third, validate that this can be an inherent uncomfortable situation and that there is a range of normal responses here and all feelings are acceptable. Also validate the feelings. Do not pretend that the patient will only feel a cramp or a touch or a pressure when they actually will experience pain, a pinch, or electric shock. We have to be fully transparent in promoting healing and validating that all feelings and emotions and sensations are normal and can be felt. And finally, establish norms of confidentiality. So ensure that there is an understanding of confidentiality policies that includes mandated reporting. So this is for patients who have children in their care, for example, or live with a domestic violent partner. And let them know that only what they agree to be in the consult note will be included. And finally, elicit strength, superpowers, and support systems. So this is just, I've actually never done that, but it's actually a training of reframing the way patients think about or behave in response to trauma. And this is critical for promoting resilience and trauma recovery. So focusing on the positives, focusing on things that they have control on, focusing on their support systems, etc. So a lot more can be said, but I wanted to leave you on some positive news and wins towards a time where trauma-informed care is the standard of care in abortion care in Canada. So first of all, the take-home messages: TIC must be the standard of reproductive health care, just as trauma affects the individual and community health. Trauma-informed reproductive healthcare demands personal and systemic practice modifications. It's critical that reproductive healthcare providers utilize TIC to support patients' healing and prevent re-traumatization. And transformational change at the level of organizations is just as valuable. So at the end of May 2024, the SOGC, which is the Society of Obstetricians and Gynecologists of Canada, which is my association basically, launched their first statement on trauma and violence-informed care in the form of an online course for its members, almost 4 years after the ACOG, or our American counterpart, published its guidelines. So they state that the gendered nature of violence is a reason why our specialty is positioned to help survivors, and this course offers a blueprint for integrating trauma-informed principles in our everyday patient care. So the goal is to develop and implement those changes to enable safer and more effective care by describing the effects of trauma on health outcomes, defining what is trauma and violence-informed care, and applying the principles of trauma and violence-informed care. So basically what we just went through in this presentation. However, this is not enough. It's not enough that it's only for the members of this association. It's not enough that it comes in so late after the beginning of medical training. You don't become a specialist until after 10 years of medical school and residency. So this is way too late in the game. This is actually what we need. Medical school curricula must start teaching the new generations of doctors about this and put emphasis on actually respecting the patients. In the United States, Dr. Sadie Eliso, who is shown here, who works with veterans at the VA in Boston, advocated for the trauma-informed physical examination to be the standard way of examining a patient, conducted research and made it happen. So now all medical schools across the US are teaching the same model of physical examination standards that are oriented on avoiding re-traumatizing patients. We need this in Canada. I feel like we are miles away, and in Quebec, miles further, but it's a beginning. I firmly believe that we are finally kind of gravitating towards a shift in education and training, as I believe that younger generations are more aware of ways to address and talk about trauma and do not shy away from uncomfortable discussions. So notably at the Université de Montréal, a new curriculum is currently underway and aims to integrate concepts of trauma-informed care in a longitudinal way. So at multiple key points in the medical training and not just as part of the physical examination. And I believe that this will be the first medical program in Canada to have such an elevated curriculum. So there's hope and a lot of great people with great ideas who somehow have to find each other. Thank you.